Good afternoon, everyone, and welcome. My name is Ty Crow. I'm the Director of Spiritual Care and Chaplaincy here at Johns Hopkins Hospital. We want to welcome you to our December Ethics for Lunch case review and time for dialogue with each of you. So thank you for participating in today's session. I know that Dr. Mark Hughes was attempting to get on here, and I understand he has a terrific spiel for how to do the CME credits. And so perhaps at some point he can get in here and share that once he's logged in. But in the meantime, we wanted to go ahead and get started and start with our case and a little bit also, I think, background on spiritual care at Johns Hopkins Hospital, because this case, as has been customary for the last several years, centers in December on some aspect of faith and or spirituality and the way that it would impact care and ways in which we can be reflective about that. So in our department here in Johns Hopkins Hospital, we do roughly about 13,000 visits with patients and patient encounters each year. And that's done primarily by staff chaplains, complemented by our CPE residents and interns, and our on-call chaplains. We're always here, so there's never a time when there's not a chaplain in the building. And one of the images I think that's fitting here as we lean into this case is that the image for a hospital chaplain in healthcare acts as a bridge. And I think that's appropriate for today, as chaplains often are bridging many aspects of care, right, for patients, bridging patients in directly into their own faith beliefs, helping them sort of identify what's important, what's meaningful. Certainly being able to bridge into concerns about care, if sometimes they will feel even more open sharing that with clergy. But then also the chaplains could be a bridge back into the patient's faith community, especially if those ties are already strong. We would hope that they would grow stronger as that patient gets discharged, hopefully home, and can find that community again. So with that being said, I want to turn our attention to the case and introduce what we were going to talk about this afternoon. And we're going to focus here on a particular faith here, the Jehovah's Witness faith, as it impacts care. All right, so this patient that we're going to present here is an 18-year-old Jehovah's Witness with a history of severe and refractory lupus. She presented to the ED with a high fever, aches and chest pain, and headaches. She's found to be a plastic crisis with all kinds of terrible numbers here, right? So hemoglobin, the neutrophil count, and then the platelet count, as well as the absolute reticulocyte counts. All of these numbers, as you can see, were low. The blood cultures were sent. She received some antibiotics. She's short of breath with a bilateral lower lobe infiltrate. So she started on this positive pressure ventilation with oxygen support. The Johns Hopkins Hospital Bloodless Medicine, their team is consulted, recommends a number of therapies. All of these are initiated quickly. The patient does not accept the packed red blood cells, the platelets, the plasma, or the white blood cells. She accepts the use of a cell saver. It's still being discussed with her and her advisors, her spiritual advisors from her church as well, whether she accepts what are considered to be minor fractionates from the plasma. The erythropoietin that she's been given does not contain albumin. I think I'm saying that right. In conversation with the medical team, the patient expresses understanding that her decision not to receive packed red blood cell transfusion puts her at a high risk, and this is a high risk for death. She states that if her heart were to stop beating, that she would not want to receive chest compressions. Therefore, her code status is updated to no CPR. She also expresses that she would want aggressive medical management up until her heart stops beating, including intubation and ventilation if necessary. Despite the aggressive treatments listed above, the patient's hemoglobin continues to drop over the next several days. She remains alert but tired, hemodynamically stable, and also on this continuous ventilation. As a last-ditch effort, the medical team offers the IVIG as a potentially beneficial treatment, specifically if the cause of her bone marrow suppression is viral. The patient shows interest in this therapy, but asked for guidance from the Bloodless medicine team prior to consenting, and after they discussed it, they decided to trial this IVIG. Due to the patient's anemia, the ICU team no longer recommended intubation, as the medications and the process that go along with intubation will likely hasten her death. The patient agrees with this, and her code status is changed to no CPR and do not intubate. Later that evening, she gradually does lose consciousness. Other therapies are stopped per her family's understanding of her wishes, and then she dies peacefully minutes later with her family at her bedside. In this case, the patient's wishes are well communicated. However, the care team expressed fear, anxiety, and a strong feeling, I would say, of helplessness, as they strongly believe that the patient's life could have been saved if she had just received a blood transfusion. The case highlights the challenges that occur when the obligation to offer standardized medical interventions runs counter to respecting a patient's faith, and in this case, honoring her religious beliefs. So at this point here, I'd like to invite our panelists to just briefly introduce themselves and their role, and then we'll hear from them in a minute on responses to the case. John, did you want to start?
Sure. My name is John Johnson. I am chairman of the Hospital Liaison Committee for Jehovah's Witnesses here in Baltimore. We are a volunteer group of about 19 members who assist Jehovah's Witnesses and hospitals when it comes to this issue of Jehovah's Witnesses and blood transfusions. We are part of a larger network nationwide where we're able to tap into medical documentation, experienced clinicians and physicians who are experts, if you will, in the use of non-blood medical management. If I look familiar to anyone, that's because I was a Hopkins employee until June 3rd of this year, when I retired after 27 years.
I'm Emily Johnson. I'm a nurse practitioner with the pediatric palliative care team, and my role is specifically embedded within both of our pediatric ICUs, so on the PICU side and also in the cardiac intensive care unit.
My name is Isha. I am the Bloodless and clinical nurse coordinator. I've been a part of the program for about 8 years at Hopkins, but I also started my nursing career at Hopkins in the IMC.
And I am Ashley Nealon. I am a nurse in our surgical ICU. I chair our safety and ethical practice committee here on the unit, and I'm also part of the hospital ethics committee. And I've been a critical care nurse for about 12 years.
Great. Well, thank you all again for being here and joining us as panelists to respond to this topic. I will highlight here before we get started that Anne has added in our chat for all to see here the directions on how to get the CME credits. I think it's pretty straightforward to following her directions. So just note that out in the chat. And so I don't want to read every question here that we put out to the group, but I will just highlight some of these objectives here, because I think there's a process here for determining, interventions based on patients' beliefs and sort of rethinking that as part of our discussion today. And certainly ways in which our medical community could benefit from input I think from not just Jehovah's Witness faith leaders, but other faith leaders, and what would that input be is an interesting question. And then certainly there's, we highlighted, if possible, hear more about the Jehovah's Witness perspectives on organ donation. As time allows, perhaps we can get some input on that, as well as transplant surgery for those who need that as well. So with that, perhaps can hand off to our panel their response to the case.
Well, I guess I will start. So the issue of blood transfusions is a fundamental belief for Jehovah's Witnesses. There are scriptures in the Bible, both Old and New Testament, that state abstain from blood, do not eat blood. Blood that leaves the body should be poured out. And while these things were written thousands of years ago, it's one of the fundamental beliefs of Jehovah's Witnesses that is still binding upon us today, as those who would try to adhere to what the scriptures say. Obviously, it can be difficult when it comes to situations like this, but this is one of our fundamental beliefs. And looking at some of the questions that came up as a part of this, I'll answer them in, I guess, two different ways. One, with things that are fundamental to Jehovah's Witnesses, but also a couple of issues relative to this particular patient. So again, there are scriptures in the Bible that we follow that say abstain from blood, and we view that as being binding to whole blood and four major components: red cells, white cells, plasma, and platelets. Fractionates that come from those components, that they are a matter of conscience. Some witnesses will say yes, some will say no. In this particular case, as an example, the erythropoietin that the patient received was albumin free because they felt that's what they want, the albumin. Nevertheless, when one of Jehovah's Witnesses decides to accept a blood transfusion, we view that as someone who has a spiritual weakness. We try to encourage them, support them. There's no stigma attached to them. They aren't shunned. If someone, say in the case of a minor, receives a transfusion because of the laws in place for minors, that is the same thing as binding there, that there's no stigma attached to that child. They're not, as some have asked, damned by the church because of receiving a blood transfusion. In the case of mature minors, individuals who can state their faith, although they may still be a minor, we've had situations where the courts have recognized that this patient's rights, because this is something that not their parents necessarily, but their faith, they have been, their wishes have been adhered to in several cases throughout the world, in fact, and definitely in this country. We do our best to, parents, like with any faith, will raise their children to be part of that faith. Many children decide to, as they become adults, to adhere to their parents' beliefs. Some decide, that's not what they want, even in the case of healthcare. In the case of this particular patient, having a chronic illness, they felt that in addition to what they believe as one of Jehovah's Witnesses from the standpoint of blood, but also in having this chronic illness, they were okay, if you will, with dying because of the years and years of treatment that they had received, and recognizing their faith, how they feel that their future will be after they pass away, one of the other fundamental beliefs of Jehovah's Witnesses. So it was not a matter of saying, well, I'm adhering to faith healing. However, this patient had been chronically ill for a long time, and maybe similar to a patient that has had a couple of rounds of chemotherapy and decides, okay, I'm done. So that's why those decisions were made relative to DNR, intubation and things like that. So, and I'll touch on one other thing that Ty mentioned. Jehovah's Witnesses and organ donation or organ transplantation, there is nothing in the scriptures that denote anything about organs. So therefore, that's a matter for each witness to decide if they wish to receive an organ. We just had a patient at Hopkins a couple of weeks ago that received a kidney. So it's up to each individual. We do have the Bloodless medicine and surgical program. They're not affiliated, if you will, with Jehovah's Witnesses from a religious organization standpoint, but obviously one that we utilize quite frequently. And Isha is, as she mentioned, the nurse that program. So I'm not sure if there's anything she wants to add relative to this particular case.
Oh, thank you, JJ. It was a very interesting case to say the least, but being a program that has been established for the past 10 years here at Johns Hopkins, this was not the first time we have seen a situation similar to this. And so we were able to, along with the hospital liaison committee, provide support and encouragement for the patient. I myself am also an active member of the Jehovah's Witness belief system, as well as our administrative coordinator, Andrew Pippa. And so we were able to support the family in the spiritual aspect as well, along with the hospital liaison committee. But also from a medical standpoint, we have a wonderful team of a medical director who's also a professor of anesthesia, Dr. Frank, professor of hematology, Dr. Risar, and our nurse practitioner, Liz. And so by able to be available 24/7 for the team, if they had any questions or concerns about treatment, we are always available. We actually pride ourselves on being available 24/7. And as Dr. Frank says, you will get a person, not a voicemail message, if you call us at 2 a.m. And this is very true. And so we were very fortunate to be able to provide the medical and also spiritual aspect for this type of patient.
And the hospital liaison committee is also available 24/7, 365. Again, we're a volunteer committee. Some of us are retired, some of us are self-employed. So we make ourselves available not only to the Jehovah's Witness community, but also to the clinicians to provide whatever assistance we can. In this particular case, this patient was originally at a different hospital. We were involved with the care there, as well as assisting with the transfer to Johns Hopkins. Thank you.
From a palliative care standpoint and meeting families in an ICU when they're at a point where their disease severity is quite high, trying to prioritize figuring out what are this patient's values, because this young lady was the age of majority, so she could make decisions for herself, but how does she like to make decisions? Who else is included in her support circle? What does she want medicine? What is she hoping for? What is she worried about? So the same questions that you want to ask and understand of anyone also apply to this case too. And so there wasn't a lot that was too different from most of the patients that we interact with in the ICU compared to questions or what information we want. Having an idea and an understanding of, how do they feel about their body? How do they understand their disease? What does this mean to them is also important. What was lovely about this family is how articulate both the patient and her support system was around her values and what made sense, what didn't, hoping for, if we can get through this, that's great, but here are my limits if we can't, and I'm okay with that. And also letting our family know that I'm okay if I don't survive. So I think from a patient and family support standpoint, this case just highlights a lot of beauty and a lot of humanity of love and what even young adults and older adolescents, how they can make decisions, how they love their families, and how they want to protect the people that love them. What was interesting, though, is then on the other side, you also have a care team that is doing so much to support, the patient in their situations and offer whatever whatever we can that fits within their value system. And then at the same time, deal with their own, like, but at the same time, I'm human. And is it really normal, like in our day and age, for people to die from anemia? And that was, a real question that we asked. And so from a palliative care standpoint, being able to support the medical team in kind of working through their thought processes of what makes sense, what's helpful, what's not helpful, and then also how can we support you in honoring this young person's wishes and values. So there was a lot that went alongside of it all, but I was really proud of all of our teams and how they worked together, because I really do think that we served this family in very respectful and dignified ways, and included them in every decision and supported what she chose. And I also echo the Bloodless medicine team. Your help and guidance was fantastic. We called you all the time, and you came and you helped us. So I think the way in which we work together, since we have this system, made the complexities that were inherent within it feel a little less burdensome and a little less anxiety provoking.
Thank you. And I think from my perspective, what stands out to me is, I think, the end of it, right? The grappling with what would often be standardized medical care. And I think that from the bedside or from a clinical standpoint, I see two things. One, the difficulty in understanding patients that come and seek, higher levels of care from other institutions, and then figuring out which pieces are okay and which pieces are not, when that often is not in line with the individual's value system. I think the other side of that is the ethical weight of being part of someone's death. And we do this regularly in terms of honoring an individual's autonomy and making decisions. And there's an ethical weight to all of it, but it feels unique in a situation where it would have been handled differently for the next patient over. So I imagine that, that feeling of helplessness and just confusion is heavy for the clinical team.
I appreciate these comments and reflections off of the case. I want to invite our group here. I see 47 people logged into our session today to utilize the chat function. If you have a question, you have an area of discussion you'd like the panelists to respond to, really invite you to go ahead and utilize that for the remaining part of our time here, and we'll do our best to respond. I can lead off here and just thinking through, part of the process, I think, for spiritual care is to help identify where patients are in their own faith and how their faith practice would impact care. I think this is one of the features that chaplains really do add to decision making, and then also the team being on board with a family in particular, and knowing that everyone is so different, right? So how people practice their faith, if you say you're this or you're that, it's likely that there's just so much nuance. And so my question really would be, maybe for Isha or for John, just how would you support and or help sort of sort through someone who is maybe just sort of minimally Jehovah's Witness or practices a little bit. They identified that as part of their sort of religious ID when they came into the hospital, and perhaps a volunteer from the Jehovah's Witness visit group meets them, but they are just sort of they have their toes in the faith per se. How does that support sort of work as they sort of travel through making medical decisions with your support?
So from a hospital liaison committee perspective, our involvement is based upon an invitation to be involved, whether it's from the hospital or someone in the family or the patient themselves. So we come in the event that our assistance is recommended. Maybe there's some questions, maybe they're having difficulty in finding someone who will provide the care with deference to their beliefs. So we are invited into a situation. With any religion, you have individuals who are raised in the faith, and that's the family religion, and some of the children or some of the family members accept it as their own, others do not. You have individuals who may have a relative or a good friend who one of Jehovah's Witnesses, or someone who for medical reasons does not want a blood transfusion. So they will come in and present themselves as such. And so we have our volunteer ministers, our patient visitation group, who come in, who are assigned to the hospital visit. And sometimes they kind of ascertain where this person is in their faith. And so we provide the assistance commensurate with what the individual actually wants, and if there's someone, as an example, who is just very minimally knowledgeable of Jehovah's Witnesses, then we kind of say, okay, if this is your decision, that's fine. However, this is usually a decision made based upon, your Bible trained conscience or your faith. And so we don't overstep our bounds, as it were, when it comes to someone who maybe, had the toe in the water. We are primarily involved with someone who is, this is my belief. These are my beliefs. This is what I want for my medical care. I want your assistance. And then it varies, to a greater or lesser degree from there.
And just to piggyback off of JJ, from a Bloodless standpoint, so the way that we find the majority of our patients is through the pastoral care census, the religious census every day. And myself and our administrative coordinator will check it at least twice a day. And so for those who select Jehovah's Witness as their religious preference, we will touch base with them. And usually as soon as we're aware of the patient being admitted into the hospital, because we know that situations can take a turn very quickly in medical care. And so we'd like to establish what their preference is before that would be the case. And so either by phone conversation, by Zoom, or in person, we're able to go and ascertain if the patient may be affiliated with the Jehovah's Witness belief via their family, or they're studying the Jehovah's Witness beliefs, or they are also a dedicated and baptized member of the Jehovah's Witness community. And so based on that, we will have a conversation with them regarding minor fractions, as was talked about in the case here. If their life were to be in danger, they would need a blood transfusion if they would accept that in their care. And we, like John said, we have a range of responses. Those who may just be studying, or their family was a part of the Jehovah's Witness community, but they themselves are not, may say, I would, in a life or death situation, accept a transfusion. However, because this is something that I know, it may be a belief I'm starting to resonate with in my heart and my truth, I would rather prefer we try other options before I receive a transfusion. And so it's really a patient decision, or the patient may say, this is just something I grew up with, but I am fine accepting transfusions. But again, a lot of our patients will say, if they are dedicated and baptized, that this is their personal belief, that they do not accept transfusions. And so we're able to guide them, the clinicians, in order to help them if that situation does arise. And then we keep a database of all of these patients, and we monitor them every day. And so we're kind of on the forefront. If we see a situation kind of taking a turn with their hemoglobin, or we see that they may need surgical interventions, then we're always able to be an advocate for that patient in whatever decision that they decided, and be able to help the clinicians in guiding through their care.
Excellent. Well, I see that there's a few questions here in our Q&A. Maybe I can just jump to them. The first one was talking about informed consent, I presume, especially for minors. So the case that we had here, was an 18-year-old. What would it look like if she was 15 per se? So I don't know if anyone would want to respond to that.
Obviously the legal side of it dictates what can be done in the event that the medical staff deems it necessary. But again, even a 15-year-old can, state very staunchly what their beliefs are. And, no one wants their child to die. This is not, again, we don't look at, this is an opportunity to be a martyr for the faith, not at all. However, children, minors make decisions all the time, based upon their own personal convictions. And so in the case of someone, 15 or 16 or even 14, being able to really ascertain what this child's, what this minor's beliefs are, how staunch they are, how determined they are, can go a long way, or should go a long way in what happens with their care.
And then just in general, when thinking about pediatric decision-making, the American Academy of Pediatrics doesn't give an age range of when kids are now able to make their own decisions. They really kind of have a spectrum of those that can't make their own decisions, some that are in between and that decisional capacity is being worked out, and then those really and truly where their decisional capacity is more formed, and it should be honored. And it is based off of developmental level and lived experience. And so there's a lot that kind of goes into how much weight do we give to the decision-making capacity and the preferences of a minor. So it can look a number of ways in a number of different cases. But as far as we do always try to be honest with the child or adolescent, get an idea of their understanding of their disease. And similar to how you establish capacity in an adult, we kind of use a similar line of questionings and understanding how the decisions fit within their family dynamics to really see what is the right decision and how much influence should the patient or the child's preferences play into what we're doing.
Excellent, thank you. And yes, I apologize. It is informed assent, certainly for minors, not consent as you would have as an adult. The other next question was, from your perspectives, how do you balance decision-making, patient's decisions being challenged by another family member? For example, patient does not want to receive blood, but a family member wants them to receive. Have you encountered anything like that?
That does happen often. And so each dedicated and baptized Jehovah's Witness is encouraged to complete a Dover power of attorney, an advance directive, which clearly states their wishes and beliefs relative to healthcare and specifically blood transfusions. And this is a signed and witnessed document, and each one is encouraged to appoint a healthcare agent and an alternate agent who will speak in their behalf. And understanding that if someone is either incapacitated or under this situation where their hemoglobin is low, family members who are not of the faith may encourage them, please take a blood transfusion. But we have the DPA, which the agents are legally allowed to speak in behalf of that patient, and it can be a tough situation because my own case, my mom and her children are Jehovah's Witnesses, but none of my family members outside of that are, and we weren't raised as such. So there's a transition period that's kind of difficult. There's a period where healthcare comes into play, but we try to legally protect ourselves, if you will, in order to make sure that patient's wishes are adhered to.
And I would say limiting care is one of the most frequent areas where families, I would say, disagree with their loved ones around death and dying, what we're doing, what we're not doing, not only limited to receiving blood transfusions. And I think the most important takeaway for the bedside clinician is to be an advocate for the patient, to be honest, and to also remain an advocate for yourself as well. These things are really difficult, and using your resources has been really helpful in that.
And if I could add one thing, Ty, the converse of that, we can also assist sometimes there is a patient who is not one of Jehovah's Witnesses, and their family member may be one of Jehovah's Witnesses. And so we also help them to appreciate that, you know, in a sense, to withhold blood from a family member is tantamount to them giving it to you. So we can assist in those situations where there's a conflict with exactly what this patient's beliefs happen to be or what the family members are saying.
Great, and maybe also connected to what you just said, Ashley. So this next question around, you know, providers feeling helpless. And I think that this is also likely common, again, not just as a result of Jehovah's Witness, but any other restrictions, right, or pulling back of care. But in, I think, recognizing the difference between healthcare providers feeling helpless and more helpless on the patients and or their families who are, quote, fine with their fate. If you've seen that, or certainly this is a live sort of dynamic in a hospital.
Yeah, no, I think that as healthcare providers, we're a piece of it. And so how our own values and how we experience things is definitely a part of this journey that I think sometimes we don't like to admit or talk about, but it's definitely a piece of it there. I think in this case in particular, which made it at least a little bit easier, is that this young lady was very much okay with dying, and her medical decisions made sense with what we felt we could achieve, and also was okay, you know, with from her faith, found a lot of comfort in the afterlife and knowing that life was going to continue even after this one. And so those things aligned, which I think made it easier. I don't know if there's ever a case where not accepting blood transfusions is a piece of it, but then also that the patient isn't okay with dying. So then that you can kind of get stuck in a way of not doing like not being able to do things that could, you know, aid in prevention of death versus those types of things. Because I feel like that's a trickier scenario to navigate when the goals don't easily align as they did in this one.
Well, I certainly can appreciate that, you know, the human experience, whether you're on the caregiver side or the care receiver side, this is really where the rubber meets the road, if you will. And to be able to acknowledge, especially as a healthcare provider, sort of what you're feeling. And many times we just sort of push through and we don't pause even for a moment to acknowledge what that feeling might be or what it's trying to tell us. And it's not like there's a judgment there. It's just a matter of acknowledging and being able to pause and maybe catch our breath as a team sometimes when we're having extra energy around a particular case. It's very common. And so this next question here: what are the faith interventions done by chaplains involved in this case, and how do chaplains serve in an interfaith encounter? Well, hospital chaplaincy, healthcare ministry is not for all clergy. For number one, to be able to put someone else's faith first is not what everyone is called to do. And it does sort of separate out what chaplaincy looks like, certainly in a hospital. So one of the first and foremost pieces of any encounter would be try to figure out what this person believes, what's most meaningful to them, and to help them sort of understand and maybe even untangle what, you know, anything that would come about in terms of impacting their care. And in this encounter, actually coming back to my original comments about being a bridge, the chaplain really deferred in some ways because this patient had such terrific spiritual support, and it was all on really good terms, right? So we would want that. We would want the support as a chaplain. If you have a connection to your faith community, there's a really powerful support showing up in the hospital. We would want to acknowledge that, uplift that, reinforce that. We're not here to replace that per se. but we can emphasize sort of how to navigate a hospital, which many people are not as familiar with. And towards the end of life, it doesn't always work, right? Sometimes there is some tension, but certainly in this case, it seemed as though the patient's wishes, their connection to their faith, and the unfortunate outcome, but it was all done in a way that I think folks were satisfied. And I think that that's sort of rare that it all comes together like that, especially when it seems so tragic. All right, so next question. Have you ever had to resort to courts to resolve such conflicts between minors and parents? I'm not sure we have a legal person on our panel here, but I don't know, John or Isha, if you all are familiar with any history here related to that.
Yes. We have had, the situation where the courts become involved. I think there are, and I'm not a legal person, but I think there are a couple of levels, if you will, that if something is emergent and two clinicians feel as if transfusion is necessary, then the transfusion can be administered. Then there are some cases where they actually the courts are involved, and then good communication can avert a lot of things. There's a patient right now, 5 years old, who is an oncology patient. And the care team was excellent in explaining to the parents the inevitabilities of a blood transfusion and understanding the quandary that they were in, understanding how that may make them feel, but also communicating what their obligations are to a minor. So with good communication, good understanding, empathy on both sides of the situation, the court situations can be averted or can be handled in a much less adversarial situation. So we've come a long way, if you will, with that over the years. The relationship between Jehovah's Witnesses and healthcare not too long ago was somewhat adversarial, but through open communication, forums such as this, the desire to understand the whole patient, things are much less adversarial. And even in the case of an oncology patient who's 5 years old and receiving tremendous amount of intervention, including chemotherapy and blood products, the situation is not adversarial. It's one where it's a collaborative effort, if you will, for the patient to stay alive.
Yes, and we again have the privilege from the Bloodless standpoint to be involved early on in the care. And so a lot of times the patient's family is comforted for minors in the fact that they know that the team is really seeking out the best interest for the child, but also looking at other alternatives. Even if it's like we had, for example, the 5-year-old that JJ's talking about, we had a meeting with her oncology team, and something as simple as just limiting phlebotomy, the amount of times that they're drawing her blood, that was important to the family because again, we want to keep as much blood as we can inside the patient. So though the families do understand with minors that at times law may supersede their own personal decision, they're very comforted by the fact that, particularly at Hopkins, we usually work as a collaborative team. And though these things may be inevitable, they are sometimes avoided through different bloodless techniques or minimized by using different bloodless techniques in their child's care.
Just a side question here. I do want to get to the next one, but what are other hospitals doing that don't have the bloodless medicine program? And I guess that's also in our history, pre-bloodless medicine program. You'd say we've come a long way. Could you just say when did we start this at Hopkins, and then can you see a contrast of other institutions that don't have a bloodless medicine program within them?
So, putting on my former Hopkins employee hat, I can say that, Hopkins is quite paternalistic over the years. And, when you're number one, like, Hopkins has been, you're used to doing things your way. However, through some of the efforts of the Hospital Liaison Committee, some of the staff here, the thinking has kind of changed. It's evolved over the years to, again, let's consider the whole patient. Some years ago, probably 25 years ago, we had a patient, a toddler with cranial synostosis, and which usually involves a lot of blood. But through using erythropoietin preoperatively and some other techniques, the child never got a drop of blood. So we're able to look at a case like this. Not that everything is a one size fits all, but looking at a case where the staff was willing to be a little more open-minded, to think a little bit outside the box, looking at the child's I think hematocrit got down to about 20. But she was otherwise healthy and hemodynamically stable. And so, just being willing to push it just a little bit without endangering the child, we had success there. Currently, we have in Baltimore, Washington area, 2 other hospitals that have bloodless medicine and surgical programs, MedStar Franklin Square and MedStar Georgetown. But we are endeavoring to make inroads into other hospitals. So typically, in this case, we had a bloodless program. You could contact Isha or Steve or Andy, whereas like this patient was at Sinai prior to, and so we were able to provide some assistance there, coming in as a Hospital Liaison Committee or HLC. So our goal is to give presentations, to come into the staff meetings, the grand rounds, whatever, and just talk more about the belief, the use of the Hospital Liaison Committee. We have access to doctors who are willing to consult with other doctors around the world, if you will. Dr. Frank is one of them as an example for anesthesia technique. So we've been able to make inroads into other hospitals, not as seamlessly right now as Johns Hopkins, but by us having meetings and discussions and presentations and helping everyone to see globally just how we are organized to assist the patients. We come a long way.
Great. Well, I'm aware of our time here, and I want to get to these at least these last 3 questions here. This one from Linda Rissar, bloodless medicine hematologist. Occasionally, rarely have patients change their minds and decide to accept blood. Of course, we honor this, and because our team includes both practicing Jehovah's Witnesses and non-Jehovah's Witnesses, we are able to accommodate this uncommon scenario, and our patients and their families seem comfortable with our care and approaches. I think that speaks to, points already made here about, being flexible, being engaged early, having conversations that are open, that there isn't pressure per se to abide in a certain direction, but to really elicit that information from the patient's family. This next question, though, is specific to the faith here. Would a Jehovah's Witness receiving blood impact their experience after death, such as going to heaven or other benefit that would be denied as a result?
So no. The quick answer is, and for future discussion, maybe Jehovah's Witnesses hope is to not, the majority to not live in heaven. So, but to live here on earth in the paradisiac conditions, is another discussion. But in any event, to answer your question, no. Again, as we mentioned, this is a fundamental belief, but if someone accepts a transfusion willingly, it's a thought of spiritual encouragement, help, compassion that they will receive. We've also had to, however, caution clinicians who have that knowledge of using that as a means. Well, you won't get in trouble if you do that. Let me do that. but no one knows what another person's conscience is going to react to receiving something against their will, or something that they willfully take at one moment and then decide later on that I didn't really want to do that. But it's not an eternal damnation, if you will, if someone accepts a blood transfusion.
Great. This next question, how do your experience with patients over time shape your advocacy approach? What have you learned that works well or not so well?
Communication works really, really well. This may be a shameless plug. However, the Hospital Liaison Committee has mentioned we are available to come in. We have a 25-minute PowerPoint presentation that we will give to the staff, nursing, social work, surgical, anyone, and explaining the beliefs, explaining the arrangement, explaining the resources that are available to clinicians and to assist, as well as the network of clinicians that we have. We have a liaison committee in Baltimore. There's one in Washington, D.C. There's several in Pennsylvania. So it's a pretty large network. We can tap into different resources. So we are available. We'd love to come in any hour of the day that works best for the staff to present just the belief, the role of the liaison committee, and how we can be a true assistance to the clinicians. So that has helped tremendously at Hopkins to some degree, but at other hospitals for sure. So call me.
Well, and you may have sort of slipped into this next question already here, but I don't know if there's literature or something that we can point to, but certainly you as a resource, the leadership of the Bloodless medicine program here would be resources for others to learn more about some of these details. But I think this question is, what would you recommend physicians and chaplains working with Jehovah's Witness patients who do not have access, I guess, to what we have here, to these types of institutional resources / programs?
So Jehovah's Witnesses, to some degree, are a word of mouth organization, if you will. So each member belongs to a congregation. The congregation has a number of elders who assist with spiritual guidance and direction, but also are a resource to provide kind of a pastoral care visit or assistance. But they also have available to them the Hospital Liaison Committee, where we can be involved, or ministers who are assigned to a specific hospital. We call a patient visitation group. So there's a large network of individuals available to the patient and the family in the event something arises. It's rare that there is someone with a major health crisis that I don't know about in some way, shape, or form, or another member of the committee knows about, because of the network that's in place. Hopkins obviously is easier because we have a rapport with Isha and Andy, Pip, and Steve, where we can get a heads up on someone that's there, or even when it comes to the pastoral care visiting of someone, to say, here's a patient, here's a situation, they may need a little more care. The patient in question, so in this case, they received, lots of support from their congregation elders, congregation members, patient visitation, and hospital liaison committee. All were involved in some way, shape, or form to provide some assistance for this patient. So those things are in place at all the major hospitals, in the metropolitan area, and we're available for that.
And one of the things I can also just put a little bit more info out about our department and how we interface, right? So as Department of Spiritual Care, we have, board certified chaplains, our chaplain residents, our per diem chaplains. Many are working within a certain framework of clinical clusters or clinical units, and are also aware, right, of what is happening sort of with particular patients, attending interdisciplinary rounds and so on. And that there is some back and forth communication, especially when one of a chaplain for the hospital were to identify someone beforehand, and or that anyone from a visitor group would notice something more intense, right? So that a chaplain can be helpful. And in this case, I think that the chaplain here was well aware of what was happening, but also knew that the spiritual support was solid, and that they could direct their energies to other patients. And that is also a great comfort on lots of levels. So.
And I forgot to mention, Tom, sorry, we do have a website, jw.org. And there is a section, medical information for clinicians, lots of resources, documentation on medical procedures, ethical and religious decisions that we make. Someone mentioned organ donation. There's a document that covers that. We have clinical strategies for OB/GYN, GI, surgery, critical care, all with links to articles, PubMed, all these other things that are available. We can make that available as well. I'm still have a Hopkins email address. And so if someone wants to shoot me an email, and I can send you a link, and as well as we have paper documentation, I guess I can make that available maybe to Emily or Ashley. So you'll have it in case anyone reaches out and wants, we have a whole presentation folder with some things in it too.
Excellent. Well, perhaps this final comment here we can conclude on here, since it's almost 1 o'clock, but from Simone. Thank you, Simone. Child Protective Services will hesitate to go to court to override a parent's wishes when religious practice is in play. When it becomes an issue of possible death, this may occur. It is a difficult path, as some medical providers threaten court intervention, either consciously or not, to coerce parents to agree to the provider's desired medical plan. The presenter's ideas of how to engage families toward a mutual planning and attempt to avoid such outsized interventions are spot on. And thank you, Simone, for that comment and affirmation of this work. It is hard work, right? But very important. Well, I am aware it is 1 o'clock. I want to be respectful of our time. I want to extend a huge sentiment of gratitude to our panelists who joined us, helped us frame this case, and were able to engage in this dialogue. Thank you to the audience for your questions. Again, hopeful this is useful. I don't know, Mark, if you need to come on here to say anything final before we conclude, or Ann?
Nope, I think we should be good.
Okay, all right. Well, thank you all, and happy holidays to each of you, however you celebrate, and best wishes for 2023.